I'm going to be taking on the job of discussing how to have conversations at the end of life, how to talk about those difficult transitions. And I'm going to talk about some very basic and fundamental principles for communication skills in general that don't only apply to medicine and can certainly be outside of the healthcare world. I'm going to talk a little bit about breaking bad news, discussing serious news with patients and their families, and give you sort of a strategy for doing that. We'll talk about transitions to end-of-life care, those really difficult conversations to have, and how to talk about CPR and code status, which has come up a few times today. And then finally, I'm going to talk a little bit about those conflicts that seem to arise at the end of life. So let's start with talking about communication, because I think that communication is probably the most important aspect of quality medical care, but also probably one of the least accomplished factors. I think that as healthcare providers, whether physicians, social workers, nurses, any healthcare providers, we tend to focus on what's important to us. And what's important to us is the medical, it's the technical. And what we fail to focus on is what's really important to the patient and to the family. And that's things like quality of life, like meaningful life. And we're going to talk more about that. We tend to do all of the talking and not much listening. And finally, we tend to use language that is difficult for patients and families to really understand. So I want to start with a question. It was a study, so one study, but in this study, what percentage of the time did physicians spend talking? So this was a taped interaction of a physician and a patient, and what period of time in that interaction did the physician spend talking? Is it A, 36%, B, 54%, C, 73%, or D, 89% of the time? So what you guys said was 89% of the time. You didn't give us as much credit as we deserve, actually. The answer is C. It's 73% of the time, which I still think is pretty crazy high percentage of the time. So we know that there are some deficits in the way that we communicate in the world of medicine. Certainly, I just mentioned that study. 87 taped discussions. Physicians spent about 73% of the time talking. They actually asked about patients' values and goals less than a third of the time in those conversations. Another study looking at 76 different, it was actually 102 ICU patients, 76 family members interviewed. These were patients who had been for 2 or more days in an ICU setting. And they interviewed the families, and more than half of the family members did not have the most basic information about prognosis, about diagnosis, about the treatment plan. Another study said that 70% of clinicians perceived conflict in their dealings specifically surrounding critically ill patients and decision making. So this is not unique to patients, it also affects clinicians. Why don't we do a better job with this? I say that it's very important and that we don't necessarily do a great job at it. And I don't think it's because we're not trying. I don't think it's because we're not good people and good clinicians. But I think there are a lot of barriers to effective communication in medicine. And one of those is the timing of these discussions. These discussions generally are not happening when they should be happening. They're happening at critical points when patients are critically ill, when they're not able to make decisions for themselves, and we're calling on surrogates to make decisions for them. We don't provide a good context for these discussions. In order to make an informed decision, patients and families have to know the prognosis. They have to know the treatment. They have to know what the options are. I mentioned before that we tend to be very procedurally focused. We focus on what matters to us, on the CPR, on the compressions, on the hemodialysis, on, you name it. That's what we're talking about. And Dr. Angelo mentioned before this this emphasis on autonomy in this country, where I think as clinicians, sometimes we feel like we can't even make a clear recommendation, where we're asking families to sort of pick from the Chinese menu to say, do you want pressors? Do you want dialysis? Do you want, this, that, and the other thing, when what we should be doing is guiding patients in these decisions. We should be offering recommendations. This is not easy to do in a limited time setting, right? As physicians, we may be seeing a patient every 15 or 20 minutes. These are not easy conversations to have in those settings. Generally, as healthcare providers, we're not very well trained to deal with strong emotions. These are difficult conversations to have, and we haven't really been trained to do this. In addition to that, we often have a mismatch of agenda from what we want to accomplish during that day to what the patient is trying to accomplish that day. And oftentimes we have no idea that that mismatch of agendas even occurred because we never took the time to really stop and ask, what are you hoping to accomplish during this visit? There's a lot of uncertainty in end-of-life care. It's very, very hard for us because we don't know what's going to happen oftentimes. We don't know. We can't give a clear prognosis. We can't say exactly 27% of the time people like you are going to get better. It's very, very difficult because we're uncertain. And then finally, we don't want to take away hope. We're afraid of frightening our patients. We're afraid of taking away hope from them. And it makes it very, very difficult. So end-of-life discussions have been associated with all of the following except, okay? End-of-life discussions are associated with all of the following except A, improved satisfaction, B, lower rates of hospitalization, C, decreased use of hospice care, or D, decreased anxiety in survivors. Yay. So this is, again, it's the audience who shows up, right? The people who already know all of this stuff who show up on days like today. But that's exactly right. The answer is that it's actually an increased use of hospice care when end-of-life wishes are discussed. So we know that talking about wishes is extremely beneficial to patients. We know that patients are more likely to have their wishes followed. If we discuss their wishes, it makes sense. They have better quality of life. They spend less time in the ICU. They have more hospice days. They have a stronger relationship with their clinician when they've had these discussions. Their families are more satisfied, and their families have less depression, less post-traumatic stress, and less anxiety after the death of the patient. So we know this is beneficial for patients. How about to clinicians, to physicians, to nurses, to social workers? We know that you become less burned out. All of the studies that look at this have shown less burnout, more satisfaction, actually less malpractice claims when we have taken the time to do this and to do it well. End-of-life conversations are procedures, just like any other procedure. This is a skill set. This is something that can be learned. This is not a mystery. You know, I took the time way back when I realized that this is what I wanted to do, and I studied it. And everything that I'm going to show you today is not original to me. I have taken this from masters in the field who really do this all the time. But what I'm going to say again is that it's very, very important when we have these conversations to really focus on what matters to the patient. Focus on what's meaningful to the patient and to their family. Focus on quality of life. Focus on what is important to you. What are you hoping to achieve now that time is limited? Do you want to be in the hospital? Do you want to be at home? What are you hoping for at this point? And really focus on that as opposed to focusing on, if your heart stops beating, should we try to bring you back? So I think that's a really important message. So we're going to start with some basic principles of communication. This is ask, tell, ask. And this applies in any aspect. Certainly it applies to end-of-life conversation, but this could be a routine office visit. This could be a nurse at the bedside. This could be a social work visit. This is from Bob Arnold and Tony Bach, who are experts in end-of-life communication, and it's a very simple strategy. So the ask in the ask, tell, ask is that you're asking the patient to provide you with some information. So you're starting by finding out what's important to the patient. So you may say something along the lines, if it's a routine office visit, of what are you hoping we would accomplish today? What's the most important thing that we talk about today during this visit? If we're talking about end-of-life care, it might be, I reviewed your records, but it's really important to me to hear, what have the other doctors told you about your condition? What have they told you that's going on? And I think this is a critical piece because this lets you know where the patient is, and it allows you to meet that patient where they are. So a patient who says to me, you know, doc, I was told that I have a lesion in my chest, it looks like cancer, and they're saying that it's metastatic cancer from somewhere else. That's a very different conversation, excuse me, than a patient who says to me, nobody's told me anything, right? I'm going to start at a very different place with that patient than with the first patient. So you have to know where the patient is, find out if there are any misconceptions or misperceptions, and that's the most important piece, is the ask. The next part is the tell. This is actually the shortest part, okay? This is where you tell them in short chunks of information what's going on, okay? So you hear where they are. They've told you that they have a lesion or a spot in their lung, and this is where you say, we believe that that lesion is lung cancer. And then you stop. It's not a point where you are going to go on and on and on, and because you're nervous and because you want to be able to tell them it's going to be okay, that you continue to speak. It's a short bit of information, and then you stop. And then you ask again, do you understand what I'm saying? Did you hear what I said? What else can I do? Can I answer any questions for you? So it's ask, tell, ask, and this applies in any aspect of conversation. Okay, so I'm going to talk a little bit about active listening, and this is where everybody in the audience kind of goes, oh my God, I have to sit here for another 45 minutes and this is what we're going to talk about. But I think this is really important. Most of what we say has nothing to do with really what comes out of our mouth. A lot of communication is nonverbal. 70% of communication is really nonverbal. So it's about the way that we are perceived by the patient. Sit down. It's amazing. Patients believe that the visit is much longer than the visit actually is if you take the time to sit down in the room with the patient, to use open posture, not to cross your arms, not to look at your watch. Most of what we do is really nonverbal. So I could be saying all the right things, but if I'm looking at my watch or my pager's going off, it becomes clear to the patient that maybe I'm not giving them my fullest attention. So I'm going to show you a little clip from Everybody Loves Raymond to kind of lighten things up a little bit here.
Perfect opportunity for you to try some active listening.
Thank you. We'll try that.
So active listening, I'm not familiar with that. Well, it's encouraging your child to express herself verbally without influencing her with your own preconceived notions or opinions.
Got it. Here we go.
Why don't we try to illustrate this with a little role play? Let's have you. Ray, is it?
No. Why don't you go, Dad?
Right. Don't be shy. Now, Ray, let's just say that I'm your daughter and I refuse to go to visit Grandma on her birthday.
Well, in this case, I happen to know Grandma, and I can't say I blame you.
Just hypothetically, Ray, all right? Now, let's just say, Ray, that you want to get from your daughter what she's really feeling. Go ahead.
Okay, daughter, you have to go to Grandma's house.
I'm not going.
Well, you have to go. It's her birthday.
I hate when you make me do things.
But I'm making you go, okay? It's Grandma's birthday. There aren't going to be many more of them.
See, I'm going to stop you just for a second, Ray. You see, I don't think at this point we need to discuss Grandma's mortality. Do we, Ray?
I'm playing the game.
It's not a game. It's okay. It's okay. Ray, if I say to you, I hate when you make me do things, perhaps you could acknowledge my feelings by saying something like, you feel you don't have any control over our plans. You understand?
That doesn't sound like something I would say.
But what she was doing was actually talking about reflection with him. And I think reflection is a really important skill to be able to have. It's something very easy to do. A reflection is really just restating what a patient says to you. And by doing that, you're letting them know that you actually care about what they're saying. You're listening to them and they're being heard. A simple reflection is really just repeating back what the patient said. So if they say to you, I can't give up hope, you just simply say, you have to keep hoping. You can't give up hope. Okay, so you're repeating back. A complex reflection is repeating back, but also adding to what they've said by sort of putting your own thoughts and your own spin on it. So if a patient says to you, or a patient's family says to you, I'm really, really upset. I don't know what to do. I feel like my kids will be devastated if I tell them about their father's illness. So instead of just repeating that back, what you're going to say back is, you're a really caring mom, and you're really concerned about what to do for your kids. And that leads them to say, yeah, I don't know if I should bring my kids into the hospital or I shouldn't. It allows them to guide the conversation for you. So reflective statements, what they do is they actually convey empathy. They empower the patient or the family to control the conversation. So a typical conversation in the office is, hi, how are you? I'm good. Are you taking your medications? Yes. How has your blood pressure been? It's been okay. So I'm guiding the conversation. When we're doing active listening or reflection, I give the opportunity to the patient or the family to guide the discussion. And that way I know that their agenda is being met in addition to my agenda. And they know that I'm trying to understand where they're coming from. So I'm going to talk very briefly about the importance of emotional data, of emotion in medicine. I think we all know that the cognitive data is that conscious intellectual processing. This is the rational side of us. This is the patient who sits in front of you in your office and says, I did all the reading, I searched on the internet, and what I saw is that there's a 10% chance that I'm going to be alive in 5 years, right? This is the rational side of that person. The emotional side of that person is the tears that are running down her face while she's saying that information to you. And that's the involuntary response. That's the fight or flight. And that's what we tend to shy away from and ignore because we're not comfortable with it. But it's probably the most important thing is that emotional data, because we use emotion to integrate data to determine what's valuable. And I think there's nothing more valuable or important in an end-of-life conversation than knowing what's meaningful to a patient. So we can't really ignore that emotion. We have to pay attention to it. Certainly, if a patient is in the middle of an emotional reaction, they're very much less likely to hear what you're saying. It's very difficult to make an educated decision when you're in the middle of an emotional response. And people want you, they want to know that you're hearing them. They want to know that that emotional part of them is being heard. So I'm going to show you a clip from a movie called Terms of Endearment. This is an oldie, but a goodie. And this is a situation in the hospital where a mother is trying to get pain medication for her daughter who is dying of cancer.
Mrs. Greenway, I was going to... Oh, good, go ahead. Just a few minutes. Well, please, it's after 10. It's after 10. I don't see why she has to have this pain. Ma'am, it's not my patient. It's time for a shot. You understand? Do something. All she has to do is hold out until 10. And it's back 10. She's in pain. Your daughter's in pain. Give her the shot. You understand? Go ahead to me. Give my daughter the shot.
So if that nurse responded to that emotional response with, well, listen, I have 7 other patients, and it's really I'm trying to do this, I'm trying to get to it, or, you know, there was an emergency in the room down the hall and it was a code and I just didn't have a chance, your mom's really important. None of that would have been effective in this situation. None of that would have been effective. What is important here is acknowledging this woman's emotions. Certainly the most important thing is to treat the patient's pain and to do that first, which this nurse was obviously going to do. But after that, responding to the patient's mom and saying things like, this must be incredibly hard, or it's amazing how you are such an advocate for your daughter, how you're here all the time. Because that's going to be a lot more effective than trying to explain the reason that the pain medication wasn't given right on time. So there's a mnemonic called NURSE, again, not something that is original to me, but is an excellent tool to just think about naming those emotions and responding to them. So the end is naming. I wonder if you might be frustrated. I wonder if you're angry based on the way that we're interacting. Understanding. I can't imagine what you must be going through. I can't imagine how hard this must be for you or for your family. Respecting, just like I just said, I'm so amazed at the advocate that you've been. This must be incredibly difficult. The S is the supporting. I will be here. I will be available to you. Here's my card. You can call me anytime. And the E is the exploring. Sometimes we don't know. You can't gauge the person who's sitting across from you. And you have to ask the question, what are you thinking? How are you feeling right now? You have to sort of know, ask to know. So we know that empathy and responding to emotion actually does matter. This was one study looking at 123 women who had breast cancer and 87 controls. And they randomized women to watch 2 different videos. One of the videos had 40 seconds of empathic language in the video. And what they found is that those 40 seconds of empathy really mattered. So these women who saw the empathic video were significantly less anxious than those who did not. So I'm going to sort of shift gears a little bit and talk about talking about serious news. So I'm going to start with a case, and we're going to use this case to sort of illustrate the journey towards end-of-life care. This is a 30-year-old woman without any past medical history, an attorney who had a new baby at home and had been feeling exhausted. She was tired, but she was a lawyer and a new mom, and she sort of ignored this, and then she was coughing and the cough wouldn't go away. So ultimately she went to her internist who treated her appropriately for a URI, and she still didn't get better. So she went back, and I think she was treated for allergies, and she was treated with antibiotics, and ultimately, over time, things didn't get better, and she had a chest x-ray. And what the chest x-ray showed was consistent with what looked like metastatic disease and diffuse metastatic disease in her chest. Ultimately, a workup showed that breast cancer was her primary. I use this example because this was actually a friend of mine, and I use this because I think we could learn a lot from it. From her experience. So what happened, the way that she found out about her cancer is that she had a phone call from the nurse in her primary physician's office who said, there are some spots or lesions on your chest x-ray and we just want to bring you in for a CAT scan to see if we can't figure out more what's going on. And she's an educated person, and she went in for the CAT scan the next day, and there was a requisition form lying there when she was left alone in the room, and she looked at the requisition, and what the requisition said was multiple nodular densities on chest x-ray rule out metastatic disease. So that's how she found out that the doctors were thinking she had cancer. Not a good way to find out, right? Alone in a room waiting for a CAT scan. So ultimately, she did go in to see her primary doctor. She came from a family of doctors, and she went with her husband, and they sat down, and he said, what the CT tells us is that this is consistent with an advanced malignancy. And he's a very good doctor, by the way. And because she came from a family of physicians and he was a friend of the family, he said, is there an oncologist that you would like to use? So this is how she found out. You likely have an advanced malignancy, and is there an oncologist that you would like to use? So a lot we can learn from that. What went wrong? I think the better question is what went right in that situation. That phone call should have been probably from the doctor to come in initially to talk about the results of the chest x-ray and the reason for the CAT scan. She should have had an opportunity to bring someone with her. She should have, we're going to go through all of these should-haves that could have happened. So let's talk about what could have been done better. So the SPIKES protocol actually comes to us from the cancer literature, and it stands for setup, perception, invitation, knowledge, empathy, and strategy. So that's SPIKES. The setup is the first and probably the most important component of all of this. So this is when you actually want to go back through the medical record, when you want to confirm the facts, especially if you're in the hospital setting. Talk to the other specialists, talk to the cardiologist and the nephrologist and all of the consultants on the case, and make sure that everybody's stories match up. Make sure that we're all on the same page. And try to create a quiet and conducive environment for a conversation like this. Have Kleenex there. Have it be quiet. Have somebody carry your pager for the course of that conversation. And the other thing is you want to let them bring someone. Tell them to bring someone for that conversation. So the P is the perception. Again, this is the ask and the ask, tell, ask. Find out what the patient understands. Not necessarily what they've been told, but what they understand. So you want to find out, what have the other doctors told you? Just, I looked in your record, but what have they been telling you? What is your understanding of why you're here or why we're doing this test? Find out where they are, again, so you can meet them where they are. I can tell you that my friend probably wouldn't have said that she's going for a CAT scan because they think that she has a cough and it's cancer. So I think that's important. And the other thing is patients have an optimistic bias, and I think they should have an optimistic bias. If you tell a patient that there's a 95% chance that they're not going to be here next year, they're going to think that they're one of the 5 who is going to be here next year. And I think we all think that way. So the I is the invitation. Before you tell them what's going on or your knowledge, you need to make sure that they're ready to hear it. There are people who don't want to know. I might start with saying, I have some patients who tell me that they want to know every detail, and I have some patients who want just a broad overview, and I have other patients who tell me, what, I'd rather have my son or my daughter make decisions for me. But I think it's important to ask before you launch into the information, because we know that different cultural backgrounds, different religious backgrounds, all kinds of different reasons that patients handle information differently. So the knowledge, this is the tell and the ask, tell, ask. This is the shortest part. Although it never is, this should be the shortest part. This is when we give a warning statement so that the patient has a chance to realize that difficult news is coming, and then we say it and we just stop talking. So again, this is the news isn't good. I'm sorry to have to tell you, but the PET scan shows that your cancer has returned. And then I'm going to stop talking, and I'm going to let them respond. I'm going to let them adjust to that information that they heard. I'm going to make sure that they understood. And then I'm not going to minimize the severity, because what we tend to do, because we're good people, is we want it to be not so bad, right? So maybe we hedge. You have this advanced cancer and it's in 4 different organs, but it's going to be okay, because we want it to be okay, but it's probably not going to be okay. So we don't want to minimize the severity of the situation. That confuses the patients, and we want to try not to use vague language like lesion or spot, even malignancy. Just say it like it is. So the empathy, this is that mnemonic nurse, right? This is where you are showing them that you see their emotion and that you care about their emotion. This is where you, again, are resisting that temptation to make it all right. And this is where you're saying, this must be incredibly hard. How can I help you through this today? The S is for summary, and this is extremely important. You want that patient to leave with a plan. Okay, they need to know what the next steps are. The plan isn't, do you have an oncologist that you'd like to use? The plan is, I have spoken with an oncologist who is an expert in lung cancer, and we're going to make you an appointment to see him, and before we do that, you're going to go get a PET scan or you're going to get a CT of your abdomen and pelvis, and this is what we're going to do. These are the next steps for you. The other thing that I think is important is that before you even talk about the plan is to ask, is it okay with you if we talk about the next steps? Because after hearing news like that, some people may not be ready to even know those next steps. But you need to make sure that they understand that you're going to be there. And I tend to give patients, even patients who I've seen for an ongoing time, I may have seen them for months or years, but I will still hand them my card as they're leaving and say that you can call the office if you think of questions that come up after you walk out, because invariably those questions will come up. Okay, so transitions to end-of-life care. It goes from depressing to more depressing, just so you know. 6 months later, Rachel comes back. And at this point, her cancer is metastasized widely. It's in bone, it's in liver. We knew it was in lung. And she's been through several rounds of chemotherapy without response. And not surprisingly, her functional status is very, very poor. And she's admitted to the hospital with a pneumonia. And her physician, who came in and sat down and took the time to really talk to her and cared about her, said, where are we going? What's going to happen next? And in the conversation with the patient and her husband, they said, she's a fighter. We want to keep fighting. And he knew that she was dying, but he didn't want to be the one to say, you're dying, and maybe we should think about other options. And so he said, we're going to continue to fight. And maybe he said that because that's what they wanted to hear or they needed to hear, but that's what he said. And so he said, we'll send you to rehab so you can get stronger. And after you're stronger, maybe we'll do another round of chemotherapy. Who has seen that scenario? Anybody in this room seen that scenario? So this is what happens, right? We don't want to be the one to have to say, listen, this isn't going to benefit you. You're not going to get stronger in rehab because you're dying. And so we keep propagating this notion of, you'll get stronger, and then we'll do something else. So when do we have a transition to end-of-life care? And I think the answer to that is that these transitions occur when prolonging life with an acceptable quality of life is really no longer an option. And this is very, very hard, because this requires patients to say that I realize that I'm not going to live longer. And it requires clinicians to say, you're right. There's really nothing in terms of curing your cancer left to do. There's a lot we can do for you, but we can't cure you. And so for clinicians, despite the fact that this is due to an overwhelming pathology, we feel like we failed, right? We feel like we failed because you're 30 and you're dying. And you're dying because you have cancer. You're not dying because I have failed you, but that's what we feel. That's what we tend to internalize, at least it's what I tend to internalize. Redirecting goals requires that you know what's important to the patient. You have to know what's important to them in order to set a goal. And you also have to know what they're giving up. What were they hoping for? What things are they leaving behind? So this is a key question. So how do you do that? So how do you talk to somebody at this point? This is where you come to the point where you say, everything that we have done to try to extend your life isn't working anymore. So now it's time for us to focus on improving your quality of life and the time that you do have. And in order to do that, I need to know what's important to you. What matters most to you at this point in the time that you have left? And somebody is going to say, it's being out in my garden, or it's going to the beach, or it's spending time with my family. It's having an opportunity, in my friend's case, to write letters to her kids, right? She could have had an opportunity to do all of those kinds of things, to be able to say, you know what, I don't want to end up in the hospital at the end of my life. I want to be home, and I want to spend as much time as I possibly can with my friends and my family. So that's the question. What are you hoping for now? What are you hoping for? And that's really the key point. The other thing that you need to understand is, what are they worried about? as you face this, what's your biggest worry? Maybe it's that I'm going to be in pain, or I'm going to die alone, or that I'm not going to be able to breathe. And you are able to alleviate a lot of those fears. A lot of those things you're able to handle. And then you can propose a new treatment plan and make a recommendation based on what you're telling me, that you don't want to be in the hospital, that you want to spend time with your family, and that you're afraid of being in pain or being in the hospital. This is what we're going to do. Maybe hospice is appropriate at this point, and we're going to put you on hospice, and we're going to keep you home, and we're going to keep you out of the hospital. And we're going to give you the support that you need to do that and to do it well. Okay, so television shows, right? What percentage, somebody else mentioned this earlier, but on TV, what percentage of the time does a patient survive after they code, after they've had CPR? Are they going to walk out of the hospital? So what percentage of the time on a TV show? And there was actually a study that looked at this. It looked at ER and Chicago Hope. Remember those shows? So it's an old study. Very well done, audience. That is the correct answer. 75% of time on TV, a patient wakes up and they walk out of the hospital. What's the reality? Does anybody know the reality of the numbers for CPR in the hospital? Yes, all correct. So it's 1 in 6 or 15% for overall. That's the entire hospital population. If you look at an ICU population, it's 2% of the time. 2%. If you look at cancer patients, it's about 5% of the time. So what do our patients see? They see 75% of the time, and they see patients waking up and walking out the door. That is not the reality. I bring that up because I want to talk about how do you talk about code status with patients, because this is something we're asked to do on a very regular basis. And as you guys all know, we are a death-denying society. We are all going to live forever. And patients have gotten to this point because of technology, right? They've gotten to this point because we've told them this works, and do this and you'll get better, and take this medication and you'll get better, and this chemotherapy will get you where you need to be. And all of a sudden we're at a point where we're saying, you know what, at this point you don't need that. And it's very hard for patients to understand, well, here you are telling me all along that this is what I need to do everything I need, every bit of medical technology, and now you're telling me that I don't. The other thing is, if a patient hasn't yet acknowledged the possibility that they could be dying, it's very, very unlikely that they are going to forego what they see as life-saving treatment. So these are difficult conversations. Again, it all kind of looks the same, right? It starts with the ask. You have to determine, what is the patient's perception of their illness? What is their understanding? Do they realize how sick they are? Do they realize what disease they have? Do they know that their heart failure actually is a terminal condition? These are the questions to start with. And then we start with, again, what matters to the patient, not what matters to me, not what matters about, am I going to do compressions? Am I going to do ACLS? Am I going to put you on a vent? That's what we tend to do, right? We go to them and we say, if your heart stops beating, would you like me to try to resuscitate you or do everything? So we say these things, but what we need to find out is what's most important to you. If you know that your time is limited, if you know that you're unlikely to live for the next 6 months, if you know that you're not likely to get out of the hospital, what's the most important thing for you right now? You have to talk in terms of the big picture. So it's not about whether we're going to try to bring you back if you die. It's about what's meaningful to you. And once I know what's meaningful to this patient, what their goals are, what they're trying to achieve, whether it's, I really want to make it to my granddaughter's wedding, and that wedding isn't for 3 months, that patient might want to be a full code and take that 2% chance that they're going to survive. Another patient may say, I absolutely want to spend the rest of my days at home. I don't want to be in the hospital. And I'm going to recommend to that patient that they choose to be a DNR, because at home, we're not going to be able to code them, and it doesn't fit with what is meaningful to that patient. So you need to frame the recommendations in terms of what aligns with the patient. The other thing is, you have to remind the patient that DNR does not mean do not treat. And I think that is a really, really important thing. It means that if you die, we're not going to try to bring you back. If your heart stops beating, you're dead. And we're not going to try to bring you back. We'll allow a natural death in that situation. But it doesn't mean that you can't have antibiotics and you can't have, X, Y, and Z. We're still going to treat you. If you die, we're not going to try to bring you back. And I think that's really important for patients and families to understand. So I'm going to end by talking a little bit about conflicts in end-of-life care. And this is something I would guess you guys have seen before. So at this point, Rachel is 31, and she left the hospital after that last admission for pneumonia and her poor functional status, and she went to rehab, subacute rehab facility, where a few days later she developed a fever, she got more short of breath, and she got sent back to the hospital. Again, something that I imagine you guys have seen before. So now she is in the ICU, and she's on a vent, and she's on pressors, and now, she's clearly failing, she's dying. And so now we've reached the point where we come to her husband and say, listen, we've done everything that we can, and now it's time to withdraw care. Okay, that terminology, which I can't stand, and we'll talk a little bit more about that, but it's time to withdraw care. So now we have a husband who has been adamant all along with his wife that she is a fighter, she's young, and nobody's ever talked about the fact that she's dying, and she's getting stronger, and she's getting the next round of chemotherapy. And that's where he is, and now we're coming at him saying, we have to take her off a vent because she's dying and we really need to make her DNR. So that's the kind of place where conflict arises. So what creates conflict? I think oftentimes pushing the family or a patient to make a decision before they've really had a chance to grieve. And there are good reasons for us needing to push families to make a decision. Don't get me wrong. I understand that we're in an ICU setting and we need to make decisions, but sometimes we need to take a step back and talk again about where we are in the illness before we start pushing families to make decisions. We tend to get caught up in the confusing medical details. We talk about the details. The nephrologist comes in and talks about the creatinine is a little bit better, or the sodium's a little bit better, and maybe the cardiologist comes in and says, well, the blood pressure is stable today on the pressors, and we're focusing on the little pieces of the puzzle, but nobody's really taking the time to focus on the patient. We focus on all of these different organ systems, but maybe not on the patient. Certainly talking too much, forcing our agenda when we don't even know what the patient's agenda is, or the family's, or offering premature reassurance. All certainly are ways that we can set ourselves up for conflict. I think the language that we use is of utmost importance. What we say and how we say it absolutely can create conflict. I think we've all heard somebody say, well, there's really nothing more we can do. That's not something that you want to say, because that's actually not true. Maybe there's nothing more that we can do to cure your cancer, but there's a lot more that we can do for you. Withdraw care. We never withdraw care from a patient. I think especially in the ICU setting, we talk about withdrawing care all the time, but think about the connotation to the family when we say we're withdrawing care. So we need to strike that from our terminology. How about, do you want us to do everything possible, right? Who is going to say, no, don't do everything, just do some of it, right? No, nobody's going to say don't do everything. That's not a question that we should be asking patients and families. And then we focus a lot on what we're going to stop. We're going to stop hemodialysis. We're going to stop chemotherapy. We're going to stop the ventilator. What we should be focusing on is what we are going to do for the patient, as opposed to what we're not going to do. So the chemotherapy is no longer working to extend his life. What we're going to do is focus on his quality of life, on his comfort. The pneumonia is getting worse even though he's on the ventilator. So we're going to work on making sure that his shortness of breath is well controlled. There's always something that we are going to do, and we really need to focus on that. The other thing is the word but. The word but oftentimes totally discounts anything that you say before it. Okay, because you're talking to a family and you say, I know that you want him to get better, but he's really, really sick. So what you're saying to them is that, yeah, he's not getting better and I'm not hearing you. So you may need to kind of do away with that and say instead, you know, he's really, really sick and yet you're still hoping he gets better. Because that sounds a heck of a lot better than, yeah, he's really sick, but there's nothing that we can really do at this point.
These are decisions about whether people are going to be alive or not alive. And if they are alive, if they're going to be living with dependence on life supports or not, or in a quality of life that may or may not be acceptable to them. The risk is that somebody ends up in a position that they absolutely do not want to be in, and they are very vulnerable and voiceless and cannot extricate themselves from that position. So she is very, very wasted, very poor nutritional status. She's had multiple amputations of her digits from her underlying disease.
Diana Reed is 31 years old and has scleroderma, a progressive disease that causes the skin to tighten and major organs to shut down.
You've got a patient who was in shock.
When she first came to the ICU 2 weeks ago, she was in respiratory distress and had to be intubated. Although Diana told doctors that she did not want to be permanently dependent on machines, her family is not ready to take her off the ventilator.
Now let's address the family situation because we did meet with them yesterday and they're coming back in today. And we have some difficult issues that we've got to address with them. What we're doing is giving her every form of support we can for all of her organs. She's getting maximum support from the respirator. She's getting medication to keep her blood pressure up. Her kidneys really haven't been working. There are clinical situations where the odds are so overwhelming that someone can survive the hospitalization in a condition that they would find acceptable. Then using this technology to support the physiology of the patient doesn't make sense. And yet, for almost everybody involved, it feels much more difficult to stop something that's already been started.
Right now, I'm on the computer relations. I'm on the respirator.
You want her on the respirator.
So I don't know if you guys all heard what the end of that conversation was, but she said, so you want to keep her on the respirator? And the family said, yes, we want to keep her on the respirator. So here's the question. Is this an unreasonable family? They're there, they're at the bedside. What do you guys think? Is that an unreasonable family? I don't think it's an unreasonable family. It may be a family who is not doing what we think that they should do, but not necessarily an unreasonable family. And I think that when we hear this, oh, this is a difficult family, this is an unreasonable family, we need to take a step back, because what can happen is those stories often get propagated, right? You hear it from one doctor to the next, or the nurse to the next nurse, and the next thing you know, nobody wants to go near that room, right? Because that's gonna be a difficult situation. And what I would urge you to do, and again, this is Bob Arnold talking, is to be curious rather than be judgmental and find out, why is this otherwise caring family making these decisions that I completely disagree with? Why is this happening? And I'm going to create a differential diagnosis for that family situation and for this conflict. So maybe it's that the family doesn't hear our story, right? It's the medical jargon. Maybe they heard from one doctor that things are going well, and the next doctor said it's not going so well. You know, we're hedging because we're really not sure what's going to be happening, and nobody wants to be the one to say, listen, this patient is dying. In addition, these are patients and families under extreme stress. They're fatigued, they're tired, they haven't slept, they're spending their days in the ICU. So maybe they're just not hearing what we're telling them. Maybe they are hearing us, but they don't actually believe us. And there's a lot of reasons that patients and families don't believe us. Maybe they had a previous experience where they were in an ICU setting and everyone said the patient wasn't going to make it, and the patient left the ICU and went home again. Maybe there's a physician in the family who is questioning what we're saying or disagreeing with the medical team. Maybe it's a cultural background issue. You know, there are all different reasons that families may be hearing us but really not believing what we're saying. And then there's denial. You know, oftentimes we hear it, but we just can't face it. And in those situations where a family's in denial, you know, just continuing to support them, offer small bits of information at a time. How about the one in the middle? I think this is probably the most frequent thing that we see, where somebody doesn't want to be responsible for shortening their loved one's life, right? They take it and they see it as a decision that they're making. And what I always try to do, and I think that we should do, is to reframe the role. It's not about that decision maker, it's about the patient, and we need to bring it back around to that. If your dad were here sitting and having this conversation, what would he say? You know, if he was able to make decisions, what would he say? Let's look at if there was a living will, what does the living will say? It's really important to reframe their role. It's not about them, it's about the patient. And what they're doing, hopefully, is simply following the patient's wishes. If it's a situation of distrust, I think that we have to just really try hard to build a relationship with that family and to focus on what we are doing for the patient, to be empathic toward that family. Oftentimes, patients believe in miracles. Families are waiting for a miracle, and it's important for us to say that we're not going to stand in the way of a miracle. And if everything that we're doing, and we won't stand in the way of any kind of a miracle for your loved one. But at the same time, we need to prepare if that miracle doesn't happen. Avoiding the what happened debate is really critical. The family's truth is their truth, and you will not be able to change that. Arguing with a family, trying to correct them, trying to tell them that you're right and they're wrong will get you nowhere except for frustrated. You don't have to respond to every question in the list of questions when you walk into the room. If they're asking you things about dopamine versus dobutamine and this med versus that med, and why is the mean arterial pressure a little bit different today than it was yesterday, oftentimes they don't really care about the specific details to those questions. And what you have to do is sort of look at the emotion behind the list of questions. You know, it must be overwhelming to be here day after day taking care of your mom. And if they still want to know what the difference between dopamine and dobutamine is, they'll continue to ask you those questions. But oftentimes, they just want to be heard. They just want to be acknowledged. And, you know, by you saying, hey, it's amazing that you're here day after day, they may say, yeah, I have, you know, other siblings, but they're not here. And I have kids at home and a husband at home, and I'm trying to do everything, and it's horrible and overwhelming. And all of a sudden, you have a relationship with that person. So when you have a family meeting to try to resolve conflicts, I think that the key point is to really explore what the family believes the patient would want. Again, it all comes back to the patient. Sometimes in family meetings, we'll leave an extra chair in the room so that when you say, if your dad was sitting here, it kind of makes that point. The underlying illness is not survivable, and no decision that we make today in this room is going to change that, I think, is a hugely important point. The underlying illness is not survivable, and we can't change that. You want to know, what was your dad like? What did he say? What did he like to do? You know, oh, he was a fisherman. He loved the outdoors. He hated being inside. He said he never wanted to be in a nursing home. Well, that guides the conversation and makes it a lot easier. Well, if he never wanted to be in a nursing home, then we probably shouldn't be doing this tracheostomy, because he's going to be requiring nursing home care once he has this trach. You know, you have to sort of reframe the role, try to get to the bottom of who is this patient as a person, so that you can guide the family in decision making. Finally, you want to frame your recommendations. So you want to link what you're telling the patient or the family, typically in a family meeting, to what they have said to you. So based on the fact that your dad said that he never wanted to be on a ventilator, we're going to stop the ventilator and focus on making him comfortable. Based on the fact that your dad said, you know, X, Y, or Z, this is what we're going to do. So you try to link the recommendation that you're making to what they're telling you the patient would have wanted. And sometimes you're not able to get through to a patient or family, and that happens. And in those times, trials of critical care, I think, are very important. But when you're setting a trial of critical care, you have to have very specific endpoints. So if in the next 24 hours we don't see an improvement in the blood pressure or the oxygen saturation, then I think that we need to meet again and determine where are we going to go from here. So that you need to have very specific endpoints when you're talking about a trial of critical care. The other thing that is hugely important is not to offer treatments that are inappropriate or don't offer benefit. And I think that we tend to get into that trap because we feel like we have to do everything. You know, the family is saying do everything, but are they saying do everything, including things that have no benefit and are only burdensome? So I think we have to think about what we're actually offering. So what happened with Rachel is that a family meeting happened. It happened with her husband and with her parents, and initially to give him time to sort of realize that she was dying and to come to grips with the whole situation, they did decide on a trial of critical care. And ultimately the decision was made to focus on comfort, and she, thank you, died in the ICU setting. So, in summary, I think using very simple techniques, just having one technique in your back pocket can go a very long way towards improving communication and end-of-life care. Talking about serious news, talking about code status, talking about transitions in care, all are things, they're learned skills. And if you take the time to learn how to do them right, it gets more and more comfortable over time. And finally, the language that we use is really of paramount importance when it comes to talking about end-of-life issues. So thank you very much. I'm happy to take any questions that you might have.